Yeah, I think, thank you, Dr. Chintan, for organizing this program on cataract surgery. And we have two very eminent speakers with us today, Professor Jagatram and Dr. Professor J.S. Titial from All Institute of Medical Sciences. I think you all know them. Professor Jagatram is the director of PGI, and he has numerous awards and best of the best awards, Oscar in ophthalmology, and contributed to numerous chapters and publications to the literature. And I don't think there's any oration in India which he has not delivered. But best of all, he was awarded, I think, the highest civilian award by the President of India, of Padma Shri. And we are very honored and very proud to be associated with him. And we are very honored that you are with us this afternoon, sir. Thank you very much for accepting this invitation and joining us this afternoon. And we also have Professor J.S. Titial, who is equally illustration ophthalmology and equally very well known. He also has a very formidable, CV, I would say, a huge CV with a number of publications, awards, honors again, on the same lines as Professor Jagatram. He has contributed some books and two books and a number of book chapters. And he was also awarded the very prestigious Padma Shri Award by the President of India for his meritorious services to the field of ophthalmology in 2015. So Professor Tatial, we are very honored to have you with us, and thank you very much.
Thank you, sir. Thank
you. And I have with me Dr. Barad. He is a former consultant at PGI Chandigarh, a colleague of ours, and currently he is running the Sangam Netralaya. It's a private practice in Chandigarh where he's doing equally well. So Dr. Barad, welcome to this program. And with this brief introduction of the faculty and the chairpersons and moderators, I'll invite our first speaker, Professor Jagatram, to deliver his keynote address on state-of-the-art pediatric cataract surgery. So over to you, Professor Jagatram, sir.
Thank you, Professor Pandav. Professor J.S. Tatial, future chief of RP Center, AIMS, New Delhi. Professor S.S. Pandav, current head, Department of Ophthalmology, PGI Chandigarh. Dr. G.S. Barad. We have with us Dr. Rohit Om Prakash and Dr. Nishant Patel. It is an honor for me to speak on state-of-art pediatric cataract surgery in Chandigarh Ophthalmological Society. While we see any of the patient of pediatric cataract surgery, any of the child with pediatric cataract, we dilate the pupil and see the anatomical configuration of the cataracts, whether it is a tripod cataract or whether it is a zonular or posterior lenticonus, or there are several issues of concern in children, such as there is a rapid axial length growth in the first 2 years of life. These children, they are uncooperative, particularly for keratometry and biometry. There is a problem of amblyopia, particularly in unilateral cataract. There are issues of timing of surgery, whether to implant a lens or not. Then there is a issues of myopic shift in the post-operative period, and there are issues of several complications. This is a surgical video of the basic pediatric cataract surgery in a child with this classical zonular cataract. While we teach students, we always tell them to stay in the anterior capsule. Make rex is about size of the rex is about 5 millimeter or so. And this tip and blue dye makes the things easier. Then after hydrodissection, remove the cortex from the capsular bag. And here, this is after rhexis. Then we perform primary posterior capsulotomy, by and large, mostly by needle cystitome, followed by utrata forceps, and try to keep the size about 3 to 3.5 millimeter. And we do vitrectomy in the zone of the posterior rhexis in the center, and implant hydrophobic acrylic IOL in the capsular bag. Here we are implanting SN60 wavefront IOL in the capsular bag, and any tag of the vitreous is removed. And by and large, we place suture in the main incision. This is another case where there is a white cataract in a child. We stain the anterior capsule with the trypan blue dye, and then do continuous curvilinear capsulorhexis after making the incision. Particularly in white cataract, this trypan blue dye is very, very helpful in perfectly making the rhexis. Then removal of the cortex from the capsular bag. And then these cortical fibril are removed from the capsular bag. 100% polishing is not possible, and then we perform posterior rhexis. And here we are implanting 3-piece IOL because we want to do capture of the optic posterior capture, where when IOL optics are in the bag and haptics are in the bag and optic in the vitreous cavity. So this is the posterior capture of the IOL. This is completion of the surgery, and this is a picture post-operatively. And then another surgical video. So this all true. These are various of the different difficult situations, whether PHPV, posterior lenticonus, double crystalline lens. Here is the first child with the posterior lenticonus. This is a classical posterior lenticonus. And hydrodissection is done, then removal of the cortex. And posterior capsule is absolutely lax. We do primary posterior capsulotomy in these young children. Implant the IOL in the bag, a lot of vitreous traction, and remove the vitreous. It helps in identifying the vitreous. Here is another child which is shown earlier also. This is a child with double crystalline lens. Probably this is the case where 2 lenses are there, and we made 2 rhexis. I'm not aware about any other case, removal of the cortex from the bag, and we implanted customized IOL into each of the capsular bag, whereas central area is aphakic, and child was given amblyopia therapy, and then child could pick up even the smallest of the object. Then comes Jonular cataract with astigmatism. Callisto was used, and here we made rhexis. This callisto also helps in that how much to achieve the rhexis, and then removal of the cortex from the bag. And because here we are implanting toric IOL in this child, and this I think most important is appropriate alignment, which has to be perfect. Removal of the removal of the viscoelastic is very important from the bag, otherwise rotation may take place. Here this is a child with uveitis, that is the JIA with uveitis, and in this child we placed a Malaysian ring, and Malaysian ring has given a very nice dilatation, adequate dilatation of the pupil we could achieve. Then of course cataract surgery is not difficult. And then placement of IOL in the capsular bag and removal of the Malaysian ring. Here we made a small peripheral iodectomy. Here we have another child with lenticular coloboma. This is a 4-year-old child. And what is important is stabilization of the capsular bag. And then we place the capsular rhexis hooks on the rhexis margin, and synechotomy done. And then for stabilization of the bag, we place a single eyelet Cioni ring into the capsular bag, and then toric IOL into capsular bag. And after removal of the hooks, this is the final picture. Here you can see before and after completion of the surgery. Then comes very other common condition. This is a not very common, that is the hemorrhagic type of THPV rhexis we have done, and we did cauterization of the vascularized membrane, and then after cutting this vascularized membrane, we have to cauterize the stalk. Here this is cauterization of the stalk, and then we remove this vascularized plaque. And of course we have to do vitrectomy in the jaw, and this is a very big vascularized plaque which is removed, vitrectomy done, and then capture of the IOL optic posteriorly, and removal of the vitreous from the anterior chamber, and any traction was removed. These are some of the other cases where we have done IOL implantation. And here what tips for success in pediatric cataract surgery are: proper pre-operative evaluation and accurate IOL power calculation, meticulous surgical technique, visual rehabilitation, that is correction of the refractive error, and occlusion therapy. Of course, long-term follow-up is important in the children. These are some of the award which we received, best of the best award, and other were winner of the ACRS award and Oscar of pediatric ophthalmology. This is purely in the field of pediatric cataract. Surgery is just the first step the follow-up is lifelong. Treatment continues beyond surgery. It is worth remembering the word of Elise. Young children with an IOL in place are unique clinical responsibility of young ophthalmologists. Long-term follow-up is especially important. And these are some of the children which we have operated. This child with cycle, we have operated for PHPV. He could see well, and majority of the other children we had bilateral cataract surgery with IOL implantation. Thank you so much for giving me this opportunity. I am thankful to Professor Tatyal and Professor Pandav, as well as I am thankful to Dr. Jaspreet and Dr. Chintan. It was nice to see Dr. Barar after a long time. Of course, Professor Tatyal is, we interact while there is examination or interview as such. Thank you so much. Thank you so much.
After a long time. Thank you so much, sir, for your wonderful presentation. And it's so gratifying to see those kids in your last slide. You know, someone is cycling, another one is, you know, doing normal activities of life. Otherwise, without intervention, I think their life would have been very, very different. I think that's what, you know, makes us, you know, your intervention so important for the society and, you know, kids. Thank you very much.
Surely, I think when parents are happy, child is happy, child can see, I think we are also happy. That is our ultimate goal, that not only surgery, but visual rehabilitation and ultimate outcome. That is most important for us.
Yes, I think because the kids, they have a long life ahead of them. And I think you are giving them such a wonderful start. So that's a fantastic. I'll request Professor Tityal to do his presentation, please. We'll keep the questions at the end. We'll have a few times. I think the last speaker is not there, so we might have a little extra time.
Okay, thank you, Dr. Panda. And I'm very thankful to entire the scientific committee of COS, especially Chintan asking me to be with my friends, especially meeting, you know, Pandav and Dr. Jakatram. I can see Barar there, you know. So we have been there for a very, very long time. And thankfully, we can contribute something to the society. It was so wonderful to see the surgery, which is like art, which we see from Professor Jagatram of an entire gamut of pediatrics scenario. Wonderful surgeries and videos, sir, and terrific surgical tips. So I've been asked to talk about posterior polar cataract, and we all do cataract surgery, and we also do have challenging situations. So I'm going to take something, some changes in technology and some tips which people can take after this presentation. No financial disclosure as such for this particular presentation from mine. Just to share a video how we perform surgery in these cases. I think one of the most important step is to have your parameters as moderate as possible. That is a FICO parameter. You have to have a, if you are doing a like Century, which Centurions where you have active fluidics, your IOPs would be less, around 50 or 45 depending on this thing. Or if you're doing other machine, then your bottle height should be a slightly in a moderate here. Rexes has to be perfect in these cases because this can be a safeguard. Subsequently, if you lose the posterior capsular support, as you saw in a pediatric surgery by Dr. Jakatram, so this can be support for putting a lensless sulcus and getting Rex's optic capture in these cases. So around 4.5 to 5 millimeter Rexes is desirable in these cases, and this is a classical posterior polar cataract. So we'll be doing a delineation first. So this is the first wave of delineation. Strengthen this delineation by putting a little jet of fluid. Don't use a syringe which is more than 2 millimeter. Then I do a gentle hydro dissection this patient, and no rotation is done in such cases. The rotation should be avoided in all posterior capsular, you can say weak capsules, which can be posterior polar or other type of cases like post-BR surgery cases. We do a sculpt type of technique. This is called layer by layer phacoemulsification. So this is basically no phaco being used at this stage. You can see 0, 0 phaco here. And take out a central core first. All posterior polar normally are softer cataracts. Rarely you'll have a harder cataract in these cases. So we'll take a primary core of nucleus first, with just aspiration sometimes the IO probe itself or a IO mode in a phaco. Then take to the epicortical cushion. Normally these are thick, it depends on how many layers of cushion you have created. So I'm taking the primary cushion, which is the innermost one, take from periphery and come to the center. So this is what is done. And you can see a disc defect in this case, which I'm going to describe subsequently, which is seen in the most posterior polar cataracts after epicortex being removed in these cases. So this is where, because delineation may not be complete sometimes, you may have to do a little manipulation with your second instrument in these cases. Then is a secondary cushion, which is the posterior part of cushion. There always strict because you have not good done hydrodissection. Peel it from periphery, leave it to the center, peel it from all sides till you can see that central part is also now free. Once the central part is free, then you are easy to aspirate the entire cortical cushion as such. So this is what I do. I normally use my phaco handpiece to complete the aspiration part also. You can leave little bit of cortex. Subsequently, you can implant the lens. And this is how you can operate nicely posterior polar cataract and preserve the weak capsule in these cases. So this is what recently we published and described. We call it intraoperative posterior polar cortical disc defect, a sign for intact posterior capsule. You can see these are various types of defects you can see in the posterior polar cataracts. If you see here, you can have a complete disc defect, or sometimes you can have incomplete disc defect because you may have aspirated the epicortex to begin with in these cases. And seen almost on 87% of cases, you can see the disc defect in these cases. And this is after the epinuclear plate aspiration. Or you can see after the primary cortex aspiration, that is after epicortical aspiration, or you can see immediately after the nucleus emulsification also. So these are three positions where you can see a disc defect in these cases. So it is important to know if you have a disc defect, the chances of a posterior capsular rupture is nil. In 9 cases out of our series, we couldn't see the disc defect. That is around 13% of the cases. And of these, 2 eyes had in-block cortical aspiration to be done because the plaque was there. And 3 out of 9 cases, the plaque was totally adherent to the posterior capsule, which is classically seen in a congenital type of posterior polar cataract sometimes. And these cases, once you peel off this adherent cortical mass, then you have this PC defect coming up in these cases. So if you see an intraoperative posterior polar cortical disc defect, it's a sign of safety. I can just show one more video here. So this is a surgery as we do, and this is a IOCT tells us which type of polar cataract we are dealing with. So this is the hydro delineation we are doing in a such case, and decompression being done. You can see hydro delineation in the IOCT clearly seen here. Subsequently, we'll do a nuclear emulsification. So this is what normally slightly harder nucleus. You can do a routine stop and chop technique in these cases and take out block by block nucleus and maintain the epicortical cushion till the end so that you don't disrupt the posterior capsule to begin with. So this is epicortic I'm removing. You can see this defect. So sometimes we might feel this is a defect in the posterior capsule, which is not. This is the classical posterior polar disc defect seen after epicortical cushion removal. That's the real safety for a surgeon at that particular moment, that you are not damaged the posterior capsule or you not open the posterior capsule in these cases. You can see pieces intact in IOCT, and you can implant any type of IOL which you have planned for the patient. You don't have to change your planning as such. So what is the role of a neural diagnostic tool like an entry segment OCT or an intra OCT, which is then a microscope to help in difficult cases like posterior capsule? I understand if you have OCT assessment of your cases, you can delineate the posterior capsule, and you can also delineate the size and thickness of posterior disc in a posterior polar cataract. And you can also see if there's a defect in the posterior capsule also, like you see in a slit lamp examination, that can be comprehended by OCT also. And same can be seen in a IOCT microscope. So this is what we classified as per the IOCT and dynamics which happens during the surgery in these cases, excluding the open posterior capsule. So we had three varieties: type 1, where you could see the entire disc clearly, and posterior capsule could be delineated throughout the entire posterior area. Type 2, central area could not see the posterior capsule. Periphery you could again see it. In type 3, entire length of a disc you could not see the posterior capsule. But type 3 we can understand, once you can't see the posterior capsule, the chances of a deficiency may be higher. So surgery is simpler in type 1 because we could delineate the posterior capsule. So we do hydrodelineation. Subsequently, we do hydrodissection wave also in these cases. So this is what we create. No rotation done. We just create a wave of hydrodissection. This is the hydrodissection and hydrodilation. Both has been done in type 1. And surgery becomes simpler subsequently. You can aspirate the nucleus, cortex. Still the capsule well maintained like you see here. And implant the IOL subsequently, which can be multifocal, toric, whichever you like to see in these cases. Type 3 is difficult as such sometimes because their posterior capsule may not be highlighted well. If you have a type 3, you may have a higher chance of posterior capsular opening in these cases, which is around 20% in our series, 2 out of 9. If you are type 1, surgery becomes simpler and less chances of a damage to the posterior capsule as such. Femtosecond, if people have access, you can create the pattern. I call a hybrid pattern here. We create the three waves of 3 rings of safety and do 8 chops. So you have a multiple blocks in each segment. You can remove each segment one by one: inner block, secondary block, tertiary block, and maintain the cushion till the end. And that also is the safety for most cases. So this is what I say. How do we decide which type of posterior polar we can do hydrodissection? So it is basically based on your initial slit lamp examination, anti-segment OCT or IOCT microscope. If you could delineate the entire length of posterior capsule underneath the disc also, those cases you can do a hydrodissection and hydrodelineation both. But if you can't delineate the posterior capsule through the disc with your examination, those cases you have to avoid hydrodissection and do just a delineation. Maybe after you remove the nucleotomy or nucleus, you can do an internal delineation in these cases subsequently. So this is a case I had total cataract. I was doing a routine surgery in this case, and routine 2.2 surgery. This was almost, I think, a 10, 12-year-old video of mine. I didn't have a subsequent such cases here. But after doing a good rhexis, I'm doing impaling the nucleus with my probe, infinity system, you can see here. Then trying to chop it from the periphery because this is like a hypermature cataract. And you need to go to periphery to chop it. So I have just lifted the nucleus so I can chop it. I thought I'll hold it again. So this is I'm trying to hold again and re-lift and chop this nucleus again. Just see the periphery here. You can see few dots, whitish dots are seen. So that's a sign that posterior capsule may not be intact in these cases. So in such cases, the nucleus will drop because the capsule will open up. And see this grains in the vitreous also signify this is a posterior polar cataract. So how do we safeguard ourselves from a total cataract cases? I think there is the importance of examination of these cases carefully if you have access to the posterior capsule through this hard nucleus. Otherwise, see the other eye. Other eye gives a lot of telltale sign type of cataract. If patient is pseudophakia, poor pseudophakia, ACIOL will also tell you that this eye total cataract will have a difficult time. To summarize my talk here, the posterior polar cataract are seen in every surgical OR. Everybody faces posterior polar cataract. So it is nice to evaluate cases pre-operatively and decide what type of posterior polar you are dealing with. And surgery should be modified accordingly. The phaco has to be layer by layer. If you have a moderate nucleus or stop and chop surgery can be done. Hydrodissection, hydrodelineation should be based on your examination. Don't do blindly hydrodissection for all cases. If you can delineate the posterior capsule clearly up to the center through a disc also, then hydrodissection is safe because surgery becomes simpler in those cases. If you have access to IOCT microscope, that might give you a little more assessment during your surgery also. Otherwise, just doing anterior segment OCT pre-op also has the same role as you have IOCT on the table. That's why I've written it does not prevent the PCR happening. The PCR in posterior polar is the anatomical or morphological feature of posterior polar cataract. If you have access to femtosecond, yes, it can definitely give you a much more customized surgery for a capsulotomy and nucleotomy, and you can customize the epicortical cushion also in those cases. So nothing to worry about posterior polar cataract, can still do a good surgery in these cases. So this year our video on posterior polar cataract IOCT guided got the runners-up trophy in this ASCRS this time. This is one of the first film award I got in ASCRS, unlike Professor Jagatram, who's been the pioneer in this field in almost all the societies. Thank you for kind listening.
This was Professor Tatial. This was just outstanding presentation, and the type of these posterior polar cataract you have shown, how to manage, and how the nucleus drop. Even we have a drop of nucleus, so it is part and parcel of the surgery. But it was just outstanding presentation.
Thank you, sir. Thank you.
Professor Titiali, you made posterior polar cataract look like so simple, like anyone can do it, but I know anyone cannot do it. So it's, I think it's the expert hand that make it and make all the difference. But that was a wonderful talk on, and I'll request all the audience to send your questions through the chat. I think we'll take them up at the end of the session, towards the end of the session. I request Dr. Barar to please introduce and invite the next speaker.
Sir, I think Dr. Rohitam Prakash is not contactable right now. So I would actually invite you, sir, Professor Pandav, to make his presentation on the finer nuances of cataract surgery in glaucoma patients. I believe if Dr. Rohit can be contacted and he joins, then maybe we can take his talk at the end of this session.
Okay, so we can, all right, so I'll load my presentation. I have to screen share, I think. Yeah, all right. Okay, so I think you had two wonderful talks earlier, and I'll give you a little bit of glaucoma perspective to my talk, no financial interest. Glaucoma and cataract, they actually coexist many times because they afflict the same age group. And glaucoma plus cataract, they are the, together they are actually the number one most important cause for, visual impairment. And problem with glaucoma is that this visual impairment is permanent, as compared to cataract, which can be so effectively treated. So what glaucoma does to vision, we all know it can lead to blindness, but before that it restricts field of vision. What is often missed or neglected or doesn't come to the consciousness is that contrast sensitivity. The glaucoma lead to a marked decrease in contrast sensitivity, and also dark adaptation is poor in these patients. So this has a significance in subsequently when we talk of the IOLs. So that should be kept in mind. On the other hand, the cataract also does reduce central vision. In contrast, glaucoma, central vision is preserved for a little longer. And it also reduces contrast sensitivity, but that can be rectified later on, as I said earlier. So when we talk about the cataract surgery and glaucoma, in glaucoma patients, so the objective is basically to improve vision, which it does, cataract surgery does. The loss of contrast and loss of field, which has happened because of glaucoma, that's going to stay, that's irreversible. IOLs that correct for corneal aberrations and lead to better contrast would, help in glaucoma patients. And functional defects which are already there, needless to say, they will compromise the final outcome. So it's very important not only to manage cataract, but you also have to manage patient expectations, because when you're doing cataract surgery, they expect a good outcome, irrespective of what the condition of the eye is. And therefore, screening for glaucoma is very important. It should not be missed in these patients. And also the patients should be told about the subsequent effect on the visual recovery in these patients, which is very important counseling part. Then some of the pre-operative considerations are other than good counseling. we keep the pressure should be well controlled before surgery. So if it's not controlled, we control it before surgery. And if it cannot be controlled, then perhaps you have to consider doing glaucoma surgery first or combining glaucoma surgery with cataract surgery. Then the glaucoma phenotype should be known, whether it's a PACG, POAG, pseudoexfoliation, or uveitis, because that can have an impact on subsequent planning of the cataract surgery and also impact on glaucoma. So if it's an angle closure patient, one can expect a little better outcome in terms of IOP control in these patients, and POAG would be, can be can have some lowering IOP, but sometimes there could be a spike in the postoperative period. But if it is pseudoexfoliation, then you have to be careful and work with these patients for any zonular instability, and the patient should be cautioned. And also the choice of IO will depend on that, or you might have to do some other procedure along with it, like put in a ring or some segmental or a full Shionese ring might be required in some of these patients. Similarly, uveitis needs to be treated, and you could have a postoperative inflammation in these patients. And they can also have uveitis, they can have glaucoma, so both of them can get worse after the surgery. So intraoperatively, again, most of the cataract surgery is done under topical anesthesia, so that suits glaucoma very well. But if you have to give a perivalvular block or retrovalvular block, then avoid adrenaline in these patients. And also, we would not like to give any pressure, during anesthesia. We prefer a corneal incision so that the superior conjunctiva remains intact for subsequent surgery if required. And during surgery, keep IOP low. I think most of the time you would be, raising IOP or your bottle height to have a pressure of, 50, 60 millimeters of mercury. But in glaucoma patient, it could be reduced. I generally operate at about 30 or 40 millimeters of pressure in these eyes. And the current generation of machines are actually very good with active fluidics, and there you can operate even at lower, bottle height or lower pressures. So choice of IOL is another issue in glaucoma patients, and because, as I said earlier, the contrast sensitivity is low, and also these patients they need a subsequent glaucoma follow-up as well, where we need to do visual field testing, we need to do OCT and the structural images. So these might be impacted by the choice of IOL, and also many of these patients have a small pupil, they have a floppy iris, they also might have zonular weakness and capsular opacification. So all these factors have to be kept in mind when you're planning IOL in these patients. So a lot of advances have happened in IOLs, and a variety of IOLs are now actually available. But I think from this glaucoma point of view, you want to put an IOL which give you the clearest or the sharpest vision with the least loss of contrast. And in that, I think aspheric monofocal IOLs, they tend to be a good choice, in general, a good choice for IOL patient. However, you could use toric and IOLs or spheric monofocal. No one actually uses these days, but torics can be used. But there would be a problem with the multifocal IOLs. So if you have a IOL which reduces the aberrations, I think because the cataract surgery, when the cataract is formed, there are a number of aberrations they are induced, and so they can be neutralized at the time of cataract surgery by using appropriate. And most of the time, choose a IOL which will be good, good visual acuity, good contrast in mesopic as well as for scotopic conditions. So you could use most of the IOLs available. As I said, the contrast sensitivity is less in these patients, and multifocal IOLs, they further reduce contrast sensitivity. So to my mind, multifocal IOLs are not suited for glaucoma patient. And if you have ocular hypertension, again, use with caution, because you don't really know which patient is going to end up with the glaucoma later on. And also these multifocal IOLs, they impact the visual field assessment. They can cause generalized reduction and in glaucoma, and also that might interfere with the detection of glaucoma or progression of glaucoma later on. You could use the FTT though in these patients with not much difference due to contrast sensitivity. Again, OCT also becomes a little unreliable in patients with multifocal IOL because it can produce its own artifacts. So ability to diagnose glaucoma may go down, or monitor glaucoma may compromised while using an OCT in glaucoma patient if you have a multifocal IOL placed in. Toric IOLs are useful in well-controlled glaucoma or when or if the surgery is unlikely to be required. But they can be used, but with some caution in mind, because there might be a change in access because of the filtering surgery. Though I think some work from AIMS suggests that that's kind of a limited, and that over a period of time it might get corrected. But one would would be a little careful in using toric IOL, or in glaucoma patients. And similarly, other issue is the power calculation. So if you have a when especially when you're doing a combined surgery, you don't know where actually the plane of the IOL is going to be after surgery. So there you could end up with some surprise in the refractive error in the post-operative period. And if the patient if the filtering surgery is done at a later date, again, there might be a shift in the lens iris diaphragm, which could upset your power calculation. So these things have to be explained to the patient and also kept in mind. And also, as I mentioned earlier, when you're doing glaucoma surgery, the pre-operative during the surgery, avoid adrenaline and keep IOP low. But very important thing is in the post-operative period as well, because many of these patients after a phacoemulsification or other cataract surgery, they have a IOP spike in the first 24 hours, which is generally doesn't affect the outcome in a routine cataract. But if you have a glaucoma, advanced glaucoma or a moderately advanced glaucoma, this could cause damage to the optic nerve. So be careful, be mindful that in the first 24 hours, you must cover up with some anti-glaucoma medicine, if required, maybe a oral, extra carbonic anhydrase inhibitor may be given in the first 24 hours to protect the optic nerve. So to summarize, glaucoma surgery is often needed in glaucoma, cataract surgery is often needed in glaucoma patients, and preoperative and intraoperative precautions are required. Choice of IOL is important. Avoid multifocal IOLs in these patients, and other IOLs can be used with some caution, especially the toric one. Keep in mind that there might be some refractive surprises if you're planning a combined surgery or you're doing a cataract surgery, glaucoma surgery, later on. But important thing is to protect the optic nerve, during the surgery as well as in the early post-operative period. Thank you very much once again, Chandigarh Ophthalmology Society, for including me into this program. Thank you.
Thank you, Dr. Pandav. This was very nice presentation. It is very true that we have to take care, particularly while implanting, while considering these multifocal toric IOL. We have to be very careful. And whatever you have said, it is very, very true for glaucoma patients. So we have to take a lot of care.
Thank you, sir.
Thank you, Professor Pandav, for detailing most of what we need to take care while handling these patients. Especially at the end of surgery, sir, also, I mean, you talked about using some of these modern machines of controlling intraocular pressure during the surgery. Even at the end of the procedure, would you be careful as far as how much you want to hydrate and form the anterior chamber, and how firm you want to leave the eye in patients with advanced glaucoma damage?
Yes, I think most phaco surgeons would like to have a positive pressure, before they let the patient go, and you will have a little tendency to over-inflate the anterior chamber. The reason is that you don't want anything to seep into the eye. But I think you are rightly said that at that point also we should be careful, because later on also the IOP is going to go up in these patients. And if you don't factor that in, then there will be time period where the pressure will be high. So definitely, I think that's a good point.
I think I am the next speaker for this session.
I think we can introduce Dr. Barad. I think there is no need to introduce Dr. Barad, because he is the extension of PGI Chandigarh, and he worked in the Advanced Eye Center, PGI Chandigarh, for more than 12 years. And he can do outstanding surgery, and he will be speaking on a beginner's misstep when starting phaco and how to avoid them. Now I request Dr. Gagandeep Barad to please share your presentation first and then.
Are you able to see the screen, sir?
Yeah, we can see the screen, but you have to select. Yeah.
Yes.
Yeah, I think you click that common mistake, or what is your PowerPoint presentation you click. Otherwise, it is as a whole at present.
Sir, can you see the screen now as a full screen?
Yeah, we can see full screen. Yeah.
Okay. Okay.
You have to.
So you have to make it full screen otherwise. But you click that common mistake or whatever title PowerPoint where you have inserted. You.
Let me just cross check it, sir.
You have to start your PowerPoint presentation.
Just a minute, sir.
Yeah.
Can you see my screen now?
Yes.
Now make it full. Make it full
Presentation
screen.
mode. Yeah.
And can you now see it as a full screen?
I think it is perfect now.
Okay, perfect. Thank you, Professor Jagatram, sir, for the kind words. It was a great pleasure and an opportunity, a lifetime opportunity for me working at PGI and learning from the leaders and doyens like you, sir. For today, Dr. Chintan asked me to speak on a beginner's missteps or mistakes when starting phaco. And the talk is essentially aimed at residents when they start phacoemulsification and some of the problems that they face and how they can settle some of those issues. Phacoemulsification is the procedure of choice. All the residents should be trained, that's given. And the Webster Dictionary would define a mistake as a wrong action or statement proceeding from faulty judgment, inadequate knowledge, or inattention. Out of all of them, I would say the inattention is the most important point that we see when our residents look at some of the masters doing surgery. If they see and analyze very carefully what the experienced surgeon is doing, they will learn a lot and they will then not repeat those same mistakes that they sometimes do when they are actually sitting on the hot seat. For most OR environments, if you put a tape on the nose, it will avoid the fogging of the eyepieces. And this for beginners can create trouble at times. They don't even realize what is happening. And before you actually start surgery, you must make sure that you have an idea of, you have checked the microscope, you have checked the eyepieces, whether they are aligned at 0 or based on your refractive error, the kind that you want to use. The settings of the microscope for illumination, the settings for red reflex. So make sure you know that the microscope is set the way you want. And the foot switch also for both the phaco machine as well as the microscope, you need to know very clearly what is going to happen when you press in a certain way. And keep a watch on machine settings. If you do surgery in multiple settings, then you must make sure that the machine is set at that kind of vacuum as well as the flow rate and the phaco power for the step that you are about to perform. So at times you may not even realize that you are actually doing surgery or a step in a totally different setting. And always sit comfortably. The one on the left here, this is, you need to be sitting comfortably, looking down at the patient with the way the surgery is being performed in most of the cases today. And you don't want to be sitting in an uncomfortable position with hands kind of outstretched, looking up towards the sky. Be very comfortable when you actually perform surgery. And this I have seen very commonly for especially the residents who are doing surgery for the first time. Many times their foot is not on the foot switch and the instruments are in the eye. And after that, they are trying to reset their foot on the foot switch of either the microscope foot switch or the phaco. So you need to sit comfortably, have both feet on the foot switches. And you also always must hold instruments in the pen grip with both hands resting on the patient's head. and you don't want to hold instruments in a way like you would hold, let's say, a spear or a javelin. You must be holding the instruments in a pen or a pencil grip to give you the maximum kind of maneuverability. And always keep the hands resting somewhere on the forehead or the cheek. Don't try to maneuver inside the eye with the hands in air. And hold instruments in the correct position. I mean, here you see the surgeon is trying to hold the phaco handpiece too far back, and the handpiece has its markings to help you kind of guide where to hold the handpiece from. So always hold the instruments from the right place, not too far back and not too far forward. And this would be the right way to hold instruments and rest the hands on the patient's forehead or the cheek, whatever the case may be. And many times, initially, I also faced this trouble, especially let's say you are doing through an incision which is more in line with your body. We are used to holding the phaco handpiece in the web between the thumb and the forefinger. And if the incision happens to be right in line with your body, it gets difficult entering the eye. So at that point of time, if you pronate the hand, it will make things much easier for you to enter the eye from and help you control the surgery. And starting from the draping, if this kind of a draping is acceptable to you, then anything during surgery is going to be acceptable to you. So you have to be perfect right from the first step. So the draping should be excellent with the eyelashes well covered by the incision drape, and only then you will start surgery. Don't use blunt instruments. Reused knives or keratomes, you may find it very hard to enter the eye and end up with an incision which is not very well constructed. And if the incision is too long, then you will end up with a lot of problems in maneuverability. And you also may end up with having a decimus detachment with all your manipulations that you are doing. So incisions should always be well fashioned and not very long, not very short. Now, incisions, that was a long incisions. Somehow this incision has gotten too wide because the surgeon has tried to widen the incision for some reason. And this is going to give you trouble in the subsequent steps. When you do the surgery through a leaky incision, this is what is going to happen. The iris always is throughout the surgery is tending to want to come out through the incision. And look here what happens after the surgery is finished. Too much injection of viscoelastic into the anterior chamber and in the wrong place. Once you realize your incision is shallow, you want to insert viscoelastic in a way that the iris does not come out. You don't want to inject too far forward and then have the iris come out. If you have a post-labral incision, if you start your surgery from through the conjunctiva, then this is a problem which you can quite commonly face. So the incision has to start in the right place, just at or beyond the insertion of the conjunctiva. So for a clear corneal incision, if it is too posterior, you will face ballooning during the procedure. And entry should always be smooth. If you are struggling for entering the anterior chamber, this is what is going to happen. The anterior chamber suddenly shallows, and you can end up with a small pupil as well. Very common mistake which residents make or have trouble with is entering the anterior chamber. You must clearly focus in your mind the direction of the incision. If you go in and keep on hitting the decimus or the posterior stroma every time, you must realize that this is not the way to go in. You come back a little, make the cannula or whatever instrument it is a little more vertical, and then gently enter, like you see here. Incisions, the two incisions, the one for the side port instrument and the main incision, should never be very close to each other or too far apart, because that will reduce the maneuverability during surgery. So the ideal would be somewhere near 40-45 degrees or so. Don't go less than 15 degree between the two, and not definitely more than 80-90 degree between the two incisions. Very important aspect is to use the incision as a fulcrum. You always go through the middle of the incision. This problem I find a lot of beginners trying to go left and right by pushing the edge of the incision. So if you go through the middle of the incision, the eye will not move. So the eye should remain practically stable when your instrument goes through the incision. And keep the hands out of the field. So hold instruments in a way that your hands are not obscuring your view during the surgery. Then coming to the CCC, start your CCC close to the center. If you start it somewhere in the periphery, you will end up taking it even more peripheral with your maneuvers. And once it starts going in that area, then you will need actually a more experienced surgeon to help you retrieve it and bring it back towards the center. So you are not going to then be able to handle it yourself. And so then an experienced person has to come and help you with the littles kind of maneuver, which you see here being performed. And then the subsequent CCC can be completed. So always start in the middle. And please don't do CCC outside the eye. Once you have a flap, many times with the shallow chamber and injection of viscoelastic like you see here, you may actually end up pushing half of the capsule outside the eye. And then, especially in the subincisional area, it can get quite difficult to re-grasp the capsule. So make sure you use the OVD intelligently, and also be careful while you are doing the subincisional part of the CCC, and not to have a flap actually come out of the main incision. This will complicate things quite a bit. And while doing the CCC, always keep a lookout for shallow chamber, because your maneuvers may actually make the chamber very shallow to flat, and the opening which you have created, you may actually have it extending radially on both the sides and give you a kind of an Argentinian flag. So you can always grasp, re-grasp, put in viscoelastic again while you're doing the surgery, and use of higher viscosity viscoelastic agents will help minimize this kind of trouble during the procedure. And then coming to the hydrodissection, at times you may, if I could just continue for a little more time.
Yes.
Because I have just a few steps to show.
We have time, Gagandeep, so don't worry.
We have lots of time, sir.
Take care.
So I'm taking the liberty because of two dropped presenters.
Yeah, please.
So the hydrodissection part, sometimes the anterior wave can be actually get mistaken as the posterior wave. So make sure you clearly see the fluid going close to the posterior capsule and passing as a wave. And then the nucleus kind of lifts gently within the capsule bag, and it tells you that the hydrodissection is complete. And before you enter with the phaco tip, make sure you have the right amount bare. It's not too less or too more advanced for that grade of cataract. And the irrigating ports are directed towards the sides in most of the cases. So make sure you have watched the tip of the phaco handpiece before you enter the anterior chamber. And while you are trying to chop, or whether you are doing a stop and chop, make sure you don't pull the nucleus once you hold. This will give you a lot of stress in this part. And same is true for you not only not pull from the front, you also don't push the nucleus while you are doing your management, because this is going to stress the zonules and give you trouble. And also when you are doing your maneuvers, most of the time the CCC is a very good marker for you not to go beyond the CCC margin with your phaco handpiece. This is not the right place. This here is the right place to impale the nucleus. And now this here is a recipe for disaster. There are eyelashes in the field, the globe is getting twisted, there is pressure on both the incisions, the eye is moving out of the field. Finally, this is going to end up in a complication. So you make sure whenever you have this kind of a situation, come out, calm yourself, get your bearings again, and then go in. And this I would not label it to the student who is doing surgery, but then finally it is the surgeon who has the responsibility to keep looking at the bottle. The bottle can finish while you are doing the procedure, especially residents will take a long time to complete the surgery. After you've taken out the nucleus, at times you may have to take out the epinucleus also with the phaco tip. Make sure you don't go deeper than the CCC margin or more peripheral than the CCC margin. This is a kind of a Lakshman Rekha if you are going to actually take it out, take the epinucleus out with the phaco tip. And if you are not sure, choose the irrigation aspiration handpiece to do it. Now you see here, when the phaco handpiece is not in the right plane, nothing is happening. And when it actually comes, the phaco tip is not even in the periphery. So the CCC margin is a very good point from where to attempt the removal of the epinucleus. And don't try to take the phaco handpiece into the subincisional part to remove the epinucleus. Please don't do that. You can rotate the part of the epinucleus with the blunt instrument in the left hand and always bring the epinucleus in front of the phaco tip to try and remove it. And the final part is when you do the cortical aspiration, at times you see these star folds, where you have actually got hold of the posterior capsule. As far as the star folds are concerned, if you hold the PC with an IA handpiece, most of the time you will not actually rupture the PC. The only thing you have to remember is don't move the hand, and then use, just release the foot pedal or use the reflux on the machine to let go of the capsule. The only place you can have a PC tear is you actually hold the capsule and then move the hand in panic, and then you rip open the posterior capsule. And the final part is when you dial the lens, it needs a kind of a vector, posterior vector to the force. And if you don't do that, then your IOL can keep on rotating either in the angle or in the sulcus. And the final mistake, as people who are learning or which we have made as well, is to start feeling that I am a good surgeon, because you are only as good as the last uncomplicated case that you performed, or you are only as good as the last complication which you had. I thank you all for the attention, and I also thank the COS for inviting me. At this point of time, I would also wish to acknowledge the Grewala Institute, where I was working at the time when this presentation was actually made. And most of these cases have been done at that point of time. Thank you so much.
Thank you, Gagandeep. I think that was a great presentation, especially for beginners who want to, learn phaco. And over a period of time, each one of us, develop our own technique. But I think learning the basics the right way is very good, and you can build on that subsequently. So that's great. I think Professor Jagatram had to leave in between. So I think we'll continue with the discussion. And are there any questions?
No, I think, Dr. Barar, wonderful tips for beginners. I think those are the points which are not written in books. The experienced surgeon can give us those tips, because surgery is such a thing. Certain things cannot be depicted on the books. And if they see videos also, they'll never realize what has to be done or what should not be done. It is the experienced surgeon telling or expressing his views, and the talented young person carefully listening to those tips and trying to correct him or herself. So that is very, very important for a young generation. And it is also compulsory for these people to record their cases and see themselves their cases subsequently, then realize what would be correct and what can be corrected subsequently. I think that is very, very important nowadays. These people have access to all the recordings of themselves, other people, and they can correct very fast. They have wet lab, they have simulators. So things have changed so much. I think the young generation pick up very, very fast, and I think these people are going to carry out better, for a society in future. But wonderful video tips. Again, it was really wonderful.
Thank you, sir. Thank you very much.
I think Professor Tital has very rightly said, because now there's a lot of material is available, YouTubes and other, even there's so many webinars. And most important thing is that the technology, the machines, they have become very good and much more reliable. When we started with I think Professor Tital must have started with some very basic phaco machine without any control whatsoever. And I think those were the hard times. And so it's I think that way we are, and the current generation is very well placed in that sense, learning phaco. But in spite of the technology, in spite of the the available material, I think it's your own perception, how you actually carefully you see those videos and how you assimilate each step is very, very important. I think when I was watching Professor Tatial's video just now about the posterior polar cataract, I mean, it looks like any other cataract. When you watch this video, you'll go with the impression that, okay, you just have to take a few additional precautions and, posterior polar is as good as like any other cataract. But I think if you notice when, those videos, the anterior chamber didn't actually fluctuate even for a moment. I didn't see any change in the depth of the the posterior chamber, and which is so important when we are doing regular cataract surgery. If you just remove your cannula and if you let your the chamber collapse or shallow, the thin membrane behind grade 1 or grade 2, but Professor Tatial said the type of posterior polar cataract, that's going to get the membrane is going to rupture, and you'll have a problem there. So I think there's so many things which go into actually a perfect surgery that sometimes you may not realize those things. So, but those things come with the repeated watching, and when you make mistakes once or twice, and then you end up learning. So that's the hard way to learn it. But I think eventually it's possible to do that. I think Professor Tatial, I think again referring to the posterior polar cataract, where you said that there's the disc defect is there, but the posterior capsule may actually be intact behind that. So do you say that they're not really a posterior polar cataracts in that sense?
No. These are a posterior polar cataract only. And we have all been seeing this defect visible during your surgery, and many people have thought that you already damaged the posterior capsule.
Yeah, we panic at times.
Nobody has classically described or depicted on literature. So we have in fact it was a sort of a prospective assessment of around 90 cases of mine, where we did an anti-segment OCT and classically discreted them. They are actual posterior polar cataract. Even this type of defect can also be seen in some of the posterior subcapsular cataract also, but they are thinner, and they normally appear towards when you remove the cortex only. In posterior polar, it depends how thick is your polar disc. If it's very thick and it is a reduplicated type of cases coming towards the nucleus, so these cases you see these defects after nucleotomy only, because you have already eaten out the part of a disc in these cases. But if you have a disc which is not too much duplicated, it is spreading horizontally much more. So defect is seen after you do a nucleotomy, when you're trying to remove that epinucleus in these cases. There are some cases where you have a very thin disc, like these are early cases. Then you see after epinucleus removal, when you're trying to remove the cortex, then you see the defect in these cases. So in fact, the classification we had given as per the IOCT, subsequently, if we have not really delineated this, we can classify according to the disc also what type of polar cataract we have seen in these cases. So this can be picked up in a routine examination with slit lamp carefully. You can see the reduplicated type. You can imagine what will happen in these cases. So I think the examination part is very, very critical in all cataracts, including posterior polar as such. But you rightly pointed out, in a surgery wise, the anterior chamber dynamics has to be absolutely stable. And people make a mistake when they come out after completing nucleotomy, when they remove their probe, they don't maintain the chamber pressure at that time. Suddenly, entire posterior capsule, the diaphragm comes up, and capsule can open up that time. So classically, what we teach people when you try to come out, don't decompress the anterior chamber. Inject some sort of a dispersive viscoelastic from the side port and maintain the chamber pressure. So every time you go in and come out, you're going to change the dynamics of entire anterior posterior chamber of your eye, and you have more chances of problem. In the routine cases also, you can have more problem with the vitreous base attachment. In these cases, CME can be there. So it is always better not to let your chamber collapse. So I think I normally don't do eye in most cases nowadays. I complete my surgery with a phaco handpiece only. So that doesn't that prevents one step to enter and come out. So that's also very important in these difficult cases. But you have to be very careful with your control of yourself, your hand, your foot control is a machine, and the machine should also have a very nice fluidics so that you don't damage the posterior capsule in this critical stage also. But yes, always make sure you rightly pointed out the chamber should be a stable, what Dr. Gagan also talked about in a basics also. And the parameter you should adjust. Don't jump to the, normally what happens at teaching institutions, they'll start surgery after the faculty has done the surgery. And they'll sit out in the same machine and without realizing what is the parameter he had set in. And they keep doing surgeries. If you ask them what was your aspiration flow rate, they have no idea. So before these people jump for a surgery, they should actually assess what should be the parameter for themselves. Then do the surgery, and that will safeguard themselves for getting a difficult situation, because the expert surgeon may have a totally different parameters for his or her comfort. So that also is a good step people have to learn. In fact, we make sure the residents have to see the machine parameter before they start surgery, and correct if needed, because sometimes they may have to decrease or increase as per their requirement.
I think that's a great point. I think the parameters, you must be mindful of the parameters. Sometimes I think we don't check before surgery. And even for experts, sometimes you are used to a particular setup, and if something, is saved, sometimes you change parameter, and before the nurse, shuts down the machine, she saves the parameters, and the wrong parameters are saved. And the next time you will get a surprise. Oh my God, what's happening? So I think is a good idea to, I think, have a checklist. I think like cataract surgery also is like, like the airlines pilot, they check 1, 2, 3 checklist. I think you have some kind of a checklist in your mind. Okay, everything is right. Starting from checking the eye you are doing, and what procedure you are doing to your phaco parameters. So I think
absolutely true, sir. Absolutely true.
That could improve the quality of your surgery and the outcome for your patient, definitely.
I think, sir, Dr. Rohit Om Prakash might be joining us. I don't know. I got a message that he may have joined us.
Is he joining? I can't see him. Actually.
Yes, he did call just now to say he's joining in, sir. I've sent him the link again. I think we can continue the discussion till he joins us.
One or two points, Dr. Panda, when patients with glaucoma, you rightly pointed out, intraocular lens should be discussed with the patient, keeping in view of a contrast in these cases. I think monofocal lenses will be the best for such cases. Other important thing is, IOP spikes, which normally we see in routine cataract surgery also. If I see my own cases out of 100, there'll be around, 5% of the cases where IOP is very high, even after doing a meticulous viscoelastic removal. And in glaucoma patient, the chances of pressure spikes may be higher because they all have a compromised anatomy as such, and even angles can be compromised sometimes. There, if you use a viscoelastic which cannot be aspirated thoroughly, because I think that's a very important part. The viscoelastic should not be, retained in these cases of glaucoma patient, because that can really have undesired spikes happening in these patients. So, normally, I think we should be giving them some sort of anti-glaucoma medications, Diamox or something for 1 or 2 days?
I think it's better to at least cover the first 24 hours. Sometimes we see the, in the post-operative period, the obvious rise in pressure, but what I suspect is, and what has also been documented, that even if you don't see any high IOP on day one, but within a few hours after surgery, there might be a phase when the pressure is actually high. And I think IOP rise, transient rise in IOP has been well documented even in non-glaucoma patients. So we don't actually examine them after 5-6 hours, but if you examine them after 5-6 hours and see the pressure, many of the patients would actually have a higher pressure than expected. So I think it's better to cover them during that phase, whether with some anti-glaucoma medicine, topical or Diamox, depending on the situation. But I think at least one should be aware that these eyes are going to experience a high IOP, or likely to experience a high IOP spike in the early postoperative period, so that it can be any damage could be avoided later on. And
I have a question for Dr. Titlani.
What is your advice regarding the people who are on a prostaglandin treatment for anti-glaucoma? So they would be stopped before cataract surgery for how long, and when can they restart, these medications after the cataract surgery?
I think ideally they should be stopped, but many a time we want to have the normal IOP also. So I think if the eye is reasonably quiet, it's not showing any drug toxicity, like it's not overtly red or anything. I think one can stop a day before surgery also, but otherwise if there's some, if the conjunctival surface is not good, you can stop a couple of weeks earlier, shift them onto an oral, and then even give some, anti-inflammatory if required, to make the ocular surface basically better for surgery. But if ocular surface is not an obvious problem, then you can actually go right up to the surgery. But after surgery, we would stop for about 4 to 6 weeks, 4 to 6 weeks, because there's a time when you could have that CME and other things. So in the post-operative period, I like to stop them for about a month. So routinely, I start them after a month if nothing has happened. And if there is some, inflammation continuing or CME or something, then we will delay it further. So that's how I would proceed with that. I think Dr. Gagandeep, I think it's mentioned very nicely that you must be very familiar with the equipment you're using for the beginners. And if you are, if your instrument is in the eye and you are fiddling with the foot switch, I think that could, lead to a disaster, complications. So I think anytime the newcomers, when you're doing a surgery, make sure they were familiar with the feel of the phaco handle, the second instrument, and also familiar with the functions of the foot switch above all. And I think in that regard, I think, like Professor Tityal said, the wet lab actually plays a very important role there. And wherever there's a facility for the wet lab, I think they get the feel of the instrument is very important. And the first time when you turn the phaco on, it has a little on feel, little on vibrations, and you know from there, is working fine or there's some problem. So I think those things, they come with time. But I think before you go to the patient, if it is done on a wet lab setting, that's always very, desirable. But if you don't have a wet lab setting, then before you put the phaco into the eye, just experiment with your foot switch and with your phaco probe and things like that. So,
Dr. Rohit is here.
Yeah, Dr. Rohit is here. Yeah.
Yeah, I think your surgeries are over, Dr. Rohit.
Yes, I'm sorry for
all white cataract you have dealt today, huh? Most welcome to this session.
We have for Dr. Rohit.
Yeah.
So can you hear me? Is my screen audible? Is my screen?
Yes, please go ahead.
Yeah. Thank you very much, Dr. Chintan and Chandigarh Ophthalmological Society for calling me over. I would be talking on pearls in managing intumescent cataracts. Well, the challenges in intumescent cataracts are primarily capsulorhexis. So I would be discussing pearls in preventing Argentinian flag sign and pearls in Argentinian flag sign if it happens. Well, talking about pearls in Argentinian flag sign, before we really go into it, I would like that we should know something how we can diagnose a fluid-filled pearly white intumescent cataract. Well, the first thing which should come in one's mind is we have to see the lens thickness, which is increased anterior-posteriorly. Subsequent to which, what happens is that the anterior chamber depth decreases. And the next point is the slit lamp examination. As you will see, you will find this under slit lamp examination. When you talk of biometry, you will find that between the L1 and L2, there will be two spikes, 2 to 3 spikes. So that will go on to diagnose that it is an intumescent cataract. And not to forget, courtesy Abhinav Dhami in his JCRS presentation, in the white angle-to-angle scan for anterior segment optical coherence topography, one finds anterior fluid pockets. Well, the basic fundamental which is involved is that there is a high lenticular pressure. And this high lenticular pressure is there in addition to the fact that there are three compartments. First, as you can see in the diagram, it's the second, number 2 labeled as 2. It is the compartment, interior compartment, and the posterior compartment. So this is something which is quite different than the Morgagnian cataracts, wherein there's hardly there's a one compartment. So with this, in these intumescent cataracts, what happens is that the posterior pressure is also has to be managed. And in these patients with intumescent cataracts, it is worthwhile giving IV mannitol preoperatively. The anterior chamber pressure is on the lower side. So we have a situation wherein there is a high intralenticular pressure with the anterior compartment pressure and the posterior compartment pressure. And there may be some posterior pressure also, which gets taken care of in some cases, by using IV mannitol. Now, the pressure dynamics which are involved is that we have to increase and equalize the pressure in the anterior chamber so that this is not less than the intralenticular pressure. So that is maintained, that is created by using a viscocohesive. This viscocohesive, if by any means viscocohesive is not used, then what happens is the moment you create an opening, because of the low pressure in the anterior chamber, the fluid makes the fluid comes out of the intralenticular material. It comes out and it creates radialization, subsequent to which you have an Argentinian flag sign. So a viscocohesive substance is used to create an anterior chamber pressure, which should not be dramatically or which should not be lower than the intralenticular pressure. So the first thing, as you can see, is the viscocohesive is there in the anterior chamber, so that flattens it. And when it flattens, it creates not a very a situation wherein post anterior capsular entry, there is not much squirting of fluid. So what we do is, as you can see, my approach in these patients depends upon the anterior chamber depth. If the anterior chamber depth is less than 2.3 millimeter, I believe that at times, there are situations wherein the high intralenticular pressure is there. So with the intraoperative OCT, as Dr. Tityal would have shown by now, that what happens is in these patients, they do a guided one, and when they find that there are pockets which are present. So in these patients, what happens is if the anterior chamber depth is less than 2.3, I use a 30 gauge needle aspiration. So what I do is I aspirate it, and when I aspirate it, that decreases the intralenticular pressure. So this is a video wherein you will find that I have already stained the anterior capsule, and I'm going into the creating a fluid, and now I am trying to aspirate it. The bevel can be down or it can be sideways according to the choice of the surgeon. Now here you will find there is a lot of concavity in this central portion. So once this concavity is there, the intralenticular pressure in the central zone is there. is on the lower side, and a small capsulorhexis can easily be completed. So next step is microincision. So here in this stage, what I'm doing is I'm not creating a large opening. With a small opening, I'm completing a small rhexis for that matter. Once that is done, what is the next thing? Well, before I go into it, so the next thing is a situation wherein the anterior chamber depth is more than 2.3 millimeter. Here, I just do not use a 30 gauge needle. I use a capsulorhexis forceps to create create a rhexis. The initiation of the rhexis is very important. You will find I'm doing a curved initiation of the rhexis because you have to give direction. Because if you don't give a direction and if you do it straight, it can extend radially. The next point is what we are doing nowadays is the reverse angled initiation. Now, what does this reverse angled initiation do? You will find in the subsequent video, when you do a reverse angled initiation, it comes directly under your view. And if by any means you are struggling to catch the capsulorhexis edge, the flap edge, you can easily do it because it has not gone to the periphery and it is directly under your view. So now once this part is done, we have a central area wherein the intralenticular pressure is less, and we have a mid-periphery and a peripheral area where the intralenticular pressure is more. If we do not take care of this, the peripheral or the mid-peripheral raised intralenticular pressure area, there can be radialization and an Argentinian flag sign. Now, Chi Soon Fake has come out with the concept of cortical milking. What she does is from the periphery, she makes the cortical material to come to the center so that the pressure in the mid periphery decreases. So after doing that, the next step is that you do the decompartmentization. In that, what is done is you slightly press it and the fluid from the posterior comes forward and there is no posterior pressure which is there. So here you will see what I'm doing. I'm doing the, debulking by the way Chi Soon Fake does it. And you will find that what I will do is once from the periphery, I'm coming to the center. And herein, what I will do is I will slightly, you will find I push it. The moment I push it and I aspirate it, I'm sure that the pressure in the posterior segment, posterior compartment has been taken care of, number one. And the mid peripheral and the peripheral pressure has also been equalized. And once that is done, you can easily complete a rhexis as if it is a normal rhexis. Once that is done, the phacoemulsification can be proceeded without any issue whatsoever. So pre-operatively, YAG laser anterior capsulotomy I've also been doing in those conditions where I feel that there's no harm in doing it. That it is done half an hour or so before surgery, and when you make a central spot, there's a sort of a cruciate sort of opening which is created, and the capsulorhexis can be easily completed. This video, you will find that puncturorhexis is being done, what has been educated by Dr. Mohan Rajan. And you will find that, but this has not caught my fancy because at times I feel that I cannot really control it. So puncturorhexis is there, but not in my scheme of things. Spiral rhexis is at times done because at times you start with the rhexis and you suddenly find that quite contrary to your belief, the intralenticular pressure is not much and you can control the capsulorhexis formation. In these situations, what you can do is you can spiral and create a spiral down and create a rhexis of your choice and of the size which you intend having. The next, so these are the different parts which are involved. The first is the reduce the posterior pressure, increase interior chamber pressure. So decompress the central area. Once that is done, create a small rhexis, reduce mid peripheral and posterior compartment pressure, and complete the rhexis. What are the pearls which are involved? You will find that here it is trying to extend. Now, what is the place where you should, inject visco into the anterior chamber? It should not be here, because if you do it here, what happens is that it can, extend the capsulorhexis to the periphery. So you should go, distal to that so that you should go distal to that so that the rhexis is the flap doesn't extend to the periphery. As you can see that, I just give me a second. So this Rexis was completed. Here, what I'm doing is, this is the way how it should be done. This is another case. You will find that the Rexis has extended to the periphery. Well, why did it extend to the periphery? Because of the simple fact that there was no microincision. There was a visco-dispersive, which was used, and I had not given any correction to it. So these are the things which then we come about the talk about the flags which can be used in these situations. You can see a volcanic eruption in these patients. Here you will find what is happening is that at no doubt the capsule rexis is not completed. By staining it is guided and you can complete the rexis. What you will find in these patients is that there is partial fragmentation and the emulsification can be completed without any issue. So what happens if there is an anterior capsular tear? So once it happens, then we are at a crossroad that what has to be done. Whether we should continue, because if we continue, at times we can complete, but there are other occasions when we have a nucleus drop. So when we because of this happens because of the simple fact that we are not sure about the extent of the tear, and we cannot appreciate the posterior extension because there is a time lag for the.
We'll have to within a, yeah, within a minute. Yeah. Next session starts within a minute.
Yeah. So the answer to the surgical dilemma is the flap motility sign and using the safe phacoemulsification techniques. So what is this flap motility sign? If by any means we find that the flap is fluttering and everted, it means it is preequatorial. And if by any means it becomes inverted and non-fluttering, it means it has become post-equatorial. Now you will see how do you see that, the moment you inject visco, you will find it has become everted. This shows it is pre-equatorial. And the moment you introduce this phaco-tip, you will find that it is fluttering. So when it is fluttering, it means that it is pre-equatorial. You just see here that it is fluttering. The site of incision is also important. It should not be parallel to it. And the rotational movements should not be quite extensive. And they should be in the direction of the tear rather than being at 90 degree. And once you have achieved the separation, and when rotation, you should try to avoid. If you have to do, you should do it minimal. And the next point which has to be done is that it has to be done in supracapsular, if you can. Here I was able to do it. The IOP has to be on the lower side. The chamber settings have to be stable. And if you can see now still that the anterior capsule is fluttering, this shows it is pre-equatorial, still it is fluttering. So, and you will find that even after the IOL has been implanted that it is fluttering. So that is for the pre-equatorial one. At times what we find is.
Thank you, Dr. Rohit. I'm afraid we'll have to stop.
Yeah, just give me a second. So in short, if we use the phacoemulsification in the presence of anterior capsular tear with flap motility sign in view, we can complete things and we can convert if required. Thank you very much for your kind attention.
Thank you very much. I think there was wonderful videos and great tips actually how to prevent capsular problems in white cataracts. That's absolutely great. Unfortunately, we have already offshore the time about a minute, so I think I'll have to close the session. Thank you, Dr. Rohit. Thank you, Dr. Tatyal and Gagadi for being in this session and contributing immensely. I think this session was actually wonderful, and we saw so many tips and tricks, for the newcomers as well as for the experts actually. So thank you all very much for joining in this session, and I'll hand over to the next session. Thank you all. Thank you. Have a great evening. Thank you.